Welcome.
Thank you.
So yeah, I guess we can restart the session. And we have John presenting. I mean, it's a big honor for me to can introduce John. You know, guys, John is this kind of person that when you start your PhD and you decide to study stroke, you always see this name coming back every time, John. And then finally, one day you have the pleasure to meet him. And this is super fascinating. You will see I think it's one of the most provocative person I met in my life, as you actually already seen a little bit already Monday and even today. And it's always super fun to speak to him. You can always learn a lot. John actually did his PhD in the UK at the Trinity College in Cambridge, and then he moved to the US where he became a neurologist first at Columbia and now is at the John Hopkins. And I think he's one of the biggest leader in stroke and motor learning and motor control. And his work has been pivotal for all of us to understand what happened in stroke and to better understand how we can promote recovery, both in research, but also he advanced a lot the field for industry and startup. And as I'm sure John will say, I recommend to all of you, students and postdocs, to read his latest book, Broken Movement, which is absolutely inspiring. And with that, I will leave the microphone to John. Please enjoy his talk.
If Elvira, you're hired to give all my introductions from now on. Can you see my screen?
Yes.
Can you see the title?
Yes.
Okay, so I'm going to start. Look, it's really, I can't tell everyone enough. I just did NeuroMatch Academy over the last couple of days, and I think with all of us stuck in our respective homes, I'm in Baltimore, the Paris of Maryland. It's extremely, it makes up for it to be part of an international event like this. And I want to thank the organizers for inviting me. I hope you don't regret it. Okay, so my title is, Why is Restoration of Motor Control in the Upper Limb After Stroke So Hard? And that's a shameless plug. That's our website on the left. That's the book that Elvira mentioned. A lot of the figures and the arguments that I'm going to make are in there, although I have updated them a little bit. Okay, so why is it so difficult to deal with stroke in humans in particular? And I'll get to that. Well, we've known since the late 19th century, early 20th century that stroke is really two diseases in humans. That leads to two sets of symptoms, negative from loss of the controlling cortex and positive from the emergence of the lower center. This is Hewlings-Jackson in London at the end of the 19th century. And then fMRI Walsh, a neurologist at Queen Square in the first half of the 20th century, also commented on this dual nature of hemiplegia, the combination of loss of voluntary movement and the intrusion of positive phenomena, spasticity and synergy. So the point is, and I think this is been known, as you can tell, for a century, and yet it's kind of been forgotten. And one of the reasons it's been forgotten, and I'm going to make this point over and over again, is that animal models don't have the positive symptoms. And so what happened is that the human rehabilitation enterprise went in one direction, very much focused on the positive symptoms, spasticity, postural abnormalities, synergies. And the animal work, especially in rodents and even in primates, went in the other direction, which was about dexterity and weakness. And I think it's really important to be talking about this at a neuroprosthetics meeting, because it's probably going to be the case that we're going to need some kind of help in order to deal with the special flavor of the hemiparetic deficit after stroke in humans that perhaps we were led to believe we might not need from the animal studies. So let's talk about some of these positive symptoms. Let's talk about the movement disorder after stroke. So basically, we've all seen these patients, right? They have these abnormal postures even at rest. Indeed, spasticity is defined as an abnormality at rest. But in addition to spasticity, there's this postural abnormality. Here you see this postural flexor pattern where your shoulder's depressed and protracted, your arm is adducted and internally rotated, the elbow's flexed and the forearm pronated, and you can see the wrist and finger flexion with clenched fists. We've all seen this, okay? Now, it's very important that this is a abnormality seen at rest. Synergies are the sort of cousin to this abnormality that you see during movement itself, okay? And the famous paper which sort of really showed this was by Twitchell, who actually did research with Denny Brown, a famous primate physiologist, where he basically described the progression of recovery of a patient after stroke and described the appearance of these abnormal synergies as patients recovered. Now, just to be clear for everyone, synergy is a little bit of a complex term because the motor control community use it a little differently from the clinical community. I'm using it in the clinical sense that synergies are unwanted co-activation of muscles and joints with failure of isolating individual joints. So for example, you may want to extend your elbow, but instead you end up flexing at the shoulder and elbow. So here's the recovery sequence. So, you know, at first you're plegic, so you could have 0.0 as plegia, and then you get some shoulder flexion, and then you get some elbow flexion. So now you see the flexor synergy. You get this concomitant flexion of the shoulder and the elbow. Then you may get some wrist and finger flexion. You could consider this the dynamic version of the static abnormality I showed you in the patient picture before. And then you can begin to get shoulder and elbow extension, and this is the extensor synergy. And then if you're lucky, you progress to extension and flexion out of the synergies. In other words, you could flex the shoulder and extend the elbow. And then you may be lucky if you can then get dexterity in the hand. This is the average sequence. The problem is that some patients get stuck somewhere at stage 2, 3, or 4, and they never escape to stages 5 and 6. So recovery of the positive symptoms, the movement disorder, is what Twitchell was describing here, okay? Now, and by the way, the Fugl-Meyer score that a lot of people use in clinical neurology was specifically devised by Fugl-Meyer to quantify that Twitchell sequence that I told you about just now. Now, just to show you how problematic these positive symptoms can be, this is a very nice study done by Kathy Zukowski and Amy Bastian, 15 years ago now, where they basically did something very clever. They took patients and gave them 2 options. They basically had them reach up to a target, position 2, or out to a target, position 1, from a resting position like this. Now, what was nice about it is in terms of having to bear the weight of your arm, it's going to be the same here and here, okay? Even though there may be some difference in momentum, all right? So they want you to see what the trajectory kinematics, a little bit like what Elvira showed, looks like in this case, okay? And what's interesting, and so here's what happens in a control subject. So you make a nice smooth reach of the hand. This is the end point up, and this is out to the target. And look at the difference here between the in synergy movement, where you reach up and your shoulder and your elbow have to flex, versus what happens when you have to do an out of synergy movement and extend the elbow while you flex the shoulder. You see this complete destruction of the kinematics when you have to make an out of synergy movement, whereas you're pretty good compared to the controls when you're within synergy. So what this nicely demonstrated, and they actually showed that the best predictor of the abnormal kinematics was not weakness. It was actually an unwanted interruption or intrusion by the movement disorder, okay? Now, the reason why this is so important is this is not described in the animal model literature, all right? Now, full disclosure, Stuart Baker and I have just received, I think, funding to try and see whether we can induce this movement abnormality in a primate model, but that's a discussion for another time. Now, one mentioning Stuart Baker explanation for this intrusive movement disorder is the idea that you upregulate another descending tract, the reticulospinal tract. Now, the reticulospinal tract originates from both old M1 premotor regions and other parts of the cortex bilaterally. And the idea here was what Stuart Baker and his team did is they basically did the classic pyramidal tract lesion to interrupt the corticospinal tract. They then stimulated in the ipsilateral medial longitudinal fasciculus, which is where the cortico-reticulospinal tract runs, and then they recorded from forearm and hand motor neurons. And they basically induced this cortical spinal stroke model. I mean, this was a lesion. And then they looked over time at what happened to the cortico-reticulospinal tract. And the bottom line is that if you look by recording from motor neurons, you see upregulation of the reticulospinal tract in forearm flexors, but not extensors. So the white is before and the gray is after. And so you see the gray goes up in the forearm flexors, and you see some in the intrinsic hand flexors. Okay. So the argument here is for some reason you're getting unwanted intrusion of the contribution of the reticulospinal tract because you lesioned the pyramidal tract. Okay. So the story that is beginning to unfold, and it's going to turn out, I'm sure, to be more complex, is that one of the reasons you get this movement disorder is you get the unmodulated intrusion of a rogue alternative descending system. Now, what about the negative symptoms? Now, the negative symptoms are particularly bad in humans compared to even work that's going back, and I describe in the book, in chimpanzees, gorillas, and orangutans. And the reason I think this is because human stroke is the price you pay for putting all your control eggs in the corticospinal tract basket. So in other words, when we're not in the position of having a stroke, we are incredibly dexterous, even compared to our primate cousins. The price we pay for this increase in dexterity is we are much more devastated by a corticospinal tract stroke even than a chimpanzee. Okay. And here's what Elvira was talking about. Here's the corticospinal tract. This is from a figure in Kandel and Schwartz that we wrote many years ago. And basically this is the idea that this new M1 originating monosynaptic corticospinal tract into the ventral horn is responsible for dexterity. Okay, so intrusive movement disorder, coarser basis functions, reticulospinal tract, fine-grained basis functions, dexterity, corticospinal tract. And for the sake of simplicity, we've got these two systems for the positive and negative symptoms of stroke. And then these are the classical studies by Lawrence and Kuipers showing this loss of dexterity when you interrupt this corticospinal tract. And here it's basically the inability to now use individual digits to extract a pellet from a food well, and you basically end up falling back on grip. And it's very interesting that there's evidence to suggest now that when it comes to grip strength, the reticulospinal tract is actually the tract involved in that, even for us in everyday life. So we have a dissociation of the movement disorder from the control disorder, is my view. Okay, and I'm going to show you some data for that. So here, interestingly, this is work by Jules DeWald, where basically he shows, and his team, that as you unweight the arms, so in other words, if all of us were to do it and we were reaching on this table, we'd be able to cover this whole area. But if you have paresis and you don't have weight support, your area of movement is crunched down like this. And the argument is this is because you can't extend the elbow because you have this intrusive synergy, as I showed you in the Sikowski and Bastian study. And so basically, only as you improve the weight around the shoulder, the weight support around the shoulder, remember this weight support is orthogonal to the direction of extension of the elbow, you begin to improve the workspace area simply by reducing the amount of weight that the patient has to support. And the idea here is that as you reduce the need to generate high levels of force, which we think is generated by the reticulospinal tract, you can tone down its level and therefore express your residual corticospinal tract. Now, if you want to now analyze in more detail the expression of the dexterity of the arm when you try and do your best to remove the intrusive synergies with weight support and frictionless surfaces, is what we do here, you basically want to see how close patients are to these planar, fully weight-supported frictionless movements. And we've argued in many papers that these straight line movements are the exact equivalent of dexterity in the finger, but they're just the measure for the arm. So this is arm dexterity, okay? So this is a healthy person. This is a mild stroke patient. In other words, you're essentially removing most of the problem of the intrusive synergy, and you still have abnormal dexterity. So the argument is that even when you remove the intrusion of the movement disorder, you're left with a dexterity disorder, presumably like Elvira was talking about, attributable to a residual cortical spinal tract. And what's interesting, these are new data of ours, is you can show the uncoupling between these synergies and motor control during recovery. So here are control subjects doing this task. Here are chronic stroke patients. Remember, the Fugl-Meyer scale is the one that I told you about, which measures synergies, and the higher the number, the better you are. So in other words, here's a Fugl-Meyer 58, the maximum is 66, so these are very mild. This is a patient with a Fugl-Meyer 29, which means they're sort of moderate to severe, and these are chronic patients, and you can see their trajectories. And now what I'm going to show you are acute patients, okay, and I'm going to try my best to match them for their Fugl-Meyer. And what you can see is that this patient is actually better with respect to synergies than this patient, but their trajectories are much worse. So in other words, what you see here is a very nice dissociation between the movement disorder, the synergies, and the dexterity of the arm as a function of your acuity versus your chronicity after stroke. And then you can basically summarize this and basically show that the Fugl-Meyer score has been well matched for the synergies, but you have a dissociation at the level of the kinematic impairment. Okay, so this is just a demonstration that we've got these two abnormalities and that they can dissociate. And the point I'm trying to make is we're going to have to come up with separate cures for these two components. So the challenge remains to reverse the positive and negative symptoms and not just compensate. So I'm just going to show you why early is important. So this is a critical window for post-stroke training. This is a professor who got a K award with me at Hopkins, Steve Zeiler. And he basically, looked at prehension movements in a rodent. Remember, I'm making the case that the negative symptoms are probably better captured in animal models as compared to the positive symptoms. And so basically you can see the little mouse reaching out, trying to pick up a pellet. You can train them to become dexterous to the point where the mouse can actually pick it up and put it in its mouth all in one smooth movement. So you can basically make a stroke in the motor cortex of the mouse. Right here, I'll show you. And like Elvira said, you can use endothelin 1. And then you can basically train the mouse over time to get better. The maximum in the mouse to do well is about 50 to 60% successful trials. Then you create the stroke. And of course, you see this reduction in reaching ability. And the point is that you can rehabilitate this poor mouse a week after the stroke and you never get back to normal behavior. Okay, so this is 3 weeks of training with a week delay in the mouse after that motor cortical stroke. All right, this is very similar to what happens to humans. They go to the stroke unit for a week and then they go to rehab and they never really recover completely. They learn to compensate. Now, the thing that Steve and the team did is that they didn't wait. They started rehabilitating immediately after the stroke. In other words, no waiting. You go within 24 hours back to normal. Okay, so this was nice because it suggested that at least for the negative symptoms, if you don't delay, you can exploit some sort of critical period with a lot of training to actually restore the behavior kinematically. All right. Now, what's nice about this is that you can prove that this is real because you can actually rescue a mouse that didn't get the training in time. In other words, again, you cause the stroke, you wait a week, you start training again. As you can see, they don't get back up there. And now we're going to do something quite perverse. We're going to give them a second stroke in premotor cortex to try and help them with their first stroke. You'll see that they get worse and then back to normal. So what we basically did here is we treated the first stroke with a second stroke. Now, of course, I am not suggesting that that's what we should do for patients going forward, but I'm saying that this result has implications, I think, for neuroprosthetics. And it's not non-specific. In other words, if you put the stroke in occipital cortex, you get nothing. Okay, so in other words, you've got to actually induce the stroke in a piece of architecture that has access to the spinal cord. I just wanted to put this up because of what Elvira said. I'm not going to go through the whole slide because of lack of time, but I wanted to show you that this critical period for restitution is also true in the monkey. This is a beautiful study which I describe in the book by Murata et al., which I suggest you take a look at. But the bottom line is that you can actually get true restitution versus compensation. They looked at both of these in this study if you start training early after stroke and you don't wait. Okay, so basically this is the monkey equivalent of the mouse study that I just showed you. And so we came up within the book this model, okay? And I think this model actually at the moment phenomenologically covers every result. I'd be very interested to see if anyone can come up with a contradiction to it, which is basically that restitution, true recovery, is a function of the amount of training that you give focused on quality of movement times the amount of residual architecture that you have that is already dedicated to movement times the plasticity level that is required in order to bring this representation online, which then combines with behavior to give restitution. The point being that there's no such thing as reorganization. It doesn't exist. What you have is upregulation through behavior and plasticity of residual dedicated architecture that was there all along. Humans. So I'm going to finish by saying, how do we in humans get from here to over here? Okay, that's what we'd like to do. All right. Now, it's very important to start early because if you quantify these trajectories, and I'm not going to go into detail how mathematically we've done this, but we have used a form of hierarchical full trajectory PCA to do this. Unfortunately, if you look at the y-axis, this is quality of movement, this is time, and basically you improve that quality of movement over the first 4 to 5 weeks, and then it flatlines. So a little bit longer than the mouse, but not much longer, where you can actually see, and this is spontaneous recovery of quality of motor control. And it's important again to point out the dissociation, which is that this is quality of motor control normalized to the first month, basically, and you do see improvement in strength, Fugelmeyer, and ARAT. So again, it's very important to be a splitter, not a lumper, and decide which of these aspects you're trying to improve after stroke, okay? So basically, here we are, mouse, monkey, human. This is measurement of the deficit. This is treatment of the deficit. And I would say at the moment in the mouse, we have evidence that we can measure kinematics and we can treat quality of movement. I think that's true in the monkey. In the human, it's an open question whether we can improve spontaneous recovery to improve motor control. We can improve strength. We can, of course, help people compensate. Oops, sorry. And synergies, the problem is these are very difficult to treat and they don't apply in mouse and monkey. So an entire aspect of the deficit in humans is completely unavailable to us in the animal models at the current time. And this is something that startlingly has been unnoticed by most of the field, in my opinion. So what do we do in humans? So we have evidence that enriched playful environments promote general recovery. So in other words, this is a patient in a hospital, alone in a hospital room. This is what patients really need. We know there's a critical period, as I've discussed. You can read these reviews if you're interested. So the question is what's the human equivalent of this? And then what do we do with the humans when we put them in the equivalent of this? And this is a study from Daniel Wolpert and his colleagues and Conrad Kerding, where they basically showed using movement analysis that all of us for the upper limb live in these statistical clouds of everyday life. So in other words, the key is to find a way to trick people to make lots of movements in this statistical donut of everyday life. So what would an enriched environment for patients look like, and how would you promote playful, non-task-based exploratory behavior? We were very much inspired by the Disney animation, which was really, animation is about movement, and we love watching movement. So we thought, well, maybe one way to trick people into making lots of movements in that statistical space of everyday life is to make people control an animal. So this is me inside a weight-supporting robot. It's the 3D version of the Jawald. Everyone becomes this dolphin bandit. Forgive me that it's a picture of me, but I think it gives you an idea of the trial. And then what we did is we took patients within the first 6 weeks of stroke, and we try to reproduce what's been done in the monkeys and the mice and look at positive and negative symptoms. Here's a basic summary, the basic point is, and just to show you, this is baseline and follow-up on a functional negative score, the ARAT, and this is the Fugelmeyer, as I told you, which captures the positive symptoms. These blues are multiple sampled control groups doing regular care. That's what you're seeing here. So we had a group that we kept dipping into and bootstrapping. And you can see that like the mice, like the monkeys, you do get better on the negative symptoms compared to regular rehab if you throw the kitchen sink in a game at the patients. But we can't seem to improve on top of basic spontaneous recovery for the positive symptoms. So here we are again, that the real problem for humans is this movement disorder. We seem to perhaps be better with the negative symptoms, at least acutely, when the plasticity is high. So why is restoration of motor control in the upper limb after stroke so hard? Well, there's a critical period that closes. It's a deficit disorder and a movement disorder. And chronically, it's unclear if training alone leads to true recovery. It may just be increased strength, peripheral effects, regular motor learning, compensation. Therefore, in the chronic stage, we may need an additional intervention to high dose and high intensity behavioral training. And the question is stem cells, drugs, or for us today, neurostimulation. Will we need some of these to basically reopen this critical period or at least reproduce it? And I will stop there. These are my collaborators and funders. And I hope I didn't go on too long. And this is the engineering team that made the dolphin and the artists. Thank you very much.
Thank you, John. Incredible talk. I have a couple of questions, but maybe I will leave the word first to the student. So, Marco, do we have a student?
Yes, it's Leo Chouaniard, who is at the Department of Science, University of Montreal.
Yes, thank you, Dr. Krakauer, for this great talk. So I'm going to go to the student's question first. So Ariel, if you want to unmute yourself.
Hi, I think that it's very, very interesting, the initiation of a critical period later in life rather than, earlier in development. And I was wondering if you think that this could potentially have any implications or be exploited for cognitive deficits that are present after stroke as well, not only just motor rehabilitation.
Oh, absolutely. I mean, I think that the whole notion of reorganization, responsiveness, possibility of restitution, and the existence of critical periods for, the most studied, as you know, is aphasia. And it's an open question whether the critical period applies as strongly to aphasia. What is true is that more training is better. The problem is that when people talk about people recovering from aphasia from a point of view of restitution, when you look at the actual data, and I've spoken to aphasia people a lot, they never really recover in the normal way after training. In other words, what's been studied the most is learning words, anomia. And the only words that patients after stroke learn with intense training are the words that they actually were trained on. It never generalizes to retrieval of words that they had but were not included in the training set. So in other words, does restitution to normal language beyond spontaneous recovery ever happen in aphasia? I think it's an open question. And is it just a form of learning word by word, and therefore you just want to do as much as you can? So it's a really interesting question whether you get generalization beyond training even early after aphasia. Now, that may not be true for neglect and other executive functions, but it's a very fascinating question, and I don't feel the jury has decided yet, and I haven't either.
Thank you. I have a question of my own. I was wondering about your expectations about what would be the effect to use a similar protocol that Elvira's presented but on the cortico-reticular spinal tract. So, yeah.
Yeah. So if I understand your question, are you saying that we should actually try and get the reticulospinal tract to help us? Are you asking whether we think it's actually useful to have it? Is that what you're saying? In other words,
if I understood correctly, you were talking about this tract as having an intrusive effect.
Mm-hmm.
So what would be your expectation when cutting that tract?
Yeah, right. That's really,
yeah.
I see. In other words, trying to interfere with it somehow. Is that what you're saying?
Yes.
Yeah, it's an extremely interesting question. Yes, I think that, you know, it's still unclear whether you need an actual abnormal upregulation of the reticulospinal tract in order for it to give you unwanted synergies. Because remember, we all use our reticulospinal tract all the time. In other words, we can benefit from its strength and synergy generating characteristics, and we can keep it under control because we have a corticospinal tract. So the question is should we, if we were to increase the efficiency of our corticospinal tract, could we both benefit from our reticulospinal tract but not have the negative effects of it? Because if we were to interfere with our reticulospinal tract, it may end up causing unacceptable levels of weakness because it's the main generator of force for all of us. So in other words, I feel like what we're going to have to do is more sophisticated than simply knocking in and knocking out. We're going to have to actually find a way to retrain the corticospinal tract to control the reticulospinal tract so we get its benefits without its downside. It's going to be more difficult.
Right, thank you. We'll go to the attendees question next. So first, when plasticity mechanism enhancing or multiplying following the proposed equation, the residual motor paths be considered somehow cortical reorganization? And if not, why?
Oh, I'm glad that was asked. There's no such thing as cortical reorganization in my view. It's one of those things that people have internalized based on a misunderstanding of classical studies going back to Merzenich and others. I think what you're actually seeing, and I didn't have time to show, but there are data, both we have our own data and there are data in monkeys, that what you see is upregulation and facilitation of pre-existing connections to the spinal cord. So let's take what Elvira said, that what's the most important predictor is your residual corticospinal tract. In other words, a tract that's already there that projects to muscles. So we all accept and nod our heads that what matters is a piece of architecture that is already dedicated to moving. Now the question is why, as I asked in my question, can't you use it immediately? Now what I would say is that you have to find a way to presumably facilitate connections from premotor areas that have access to that residual corticospinal tract. And the analogy I would use is if you are unfortunate enough to lose your hand and you get a hand transplant or even a prosthetic, you need to become skilled with that hand transplant and prosthetic with architecture already dedicated to controlling, you know, effectors of some kind. So cortical reorganization is one of those words that suggests that some magical property of cortex is in place where it can qualitatively switch identities, like your occipital cortex can suddenly become sensory cortex, or a hand area can suddenly, a face area, I should say, can suddenly become a hand area. This sort of magical change in identity that allows you to reassign a cortical area to a new job. And what I'm saying is, it doesn't happen. What happens is that you have, luckily, enough redundancy in the system and residual architecture already dedicated to that function that you can upregulate through a gain mechanism to use again.
Thank you. Karen, yeah. Great.
Hi, in your concluding statements, you mentioned the possibility of cortical stimulation of being able to reopen the critical period. Has there been any animal work in this, or what is the closest work to this so far that you know of?
You know what? There's been, you know, we've done some work and others have done classic work, you know, using SSRIs to try and do that. In other words, amblyopia, V1, Takao Hensch has done some really interesting work, you know, trying to do that. We actually used, basically did the experiment I showed you where we gave fluoxetine, Prozac, to the mice early after their stroke, and then we waited. In other words, we did the wait. But having given them fluoxetine early, they responded in the same way to the training after a delay as they did if you started right away. So in other words, it was interesting that the drug seemed to maintain the critical period, but if you gave the drug late, you couldn't reopen it with the drug, right? So Dale Corbett has also shown that you can't reopen it, maybe you can just maintain it. Now, in terms of invasive approaches, I'm not aware of any so far that have specifically tried to use some kind of invasive, you know, neurostimulation approach, specifically with that question in mind. I'm actually not familiar with it. So it's a wide open field, basically.
I'll go to another audience question next. I think that some strokes get improvement on ARAT, but not on Fugl-Meyer due to the fact that improvement on ARAT may come from movement compensation, which does not reflect a real recovery.
Yeah, that's an incredibly important question. And in fact, in the paper that we're just about to submit on this, we address exactly that. So the ARAT is one of these frustrating tasks, which is both closest to what people have used in the mouse and the monkey. It's a prehension task where you pick up objects. But it also is scored in such a way that you could do well on it purely on the basis of compensation. Okay. Now, the answer I have to your question is that if the changes in the ARAT, which were quite large in our study, were just compensation, then we shouldn't have gotten changes any larger than people have seen chronically, because you can learn to compensate at any time for your deficit. So what I would argue is three things. The magnitude of the change in the ARAT that we got compared to what's been seen with equivalent amounts of training chronically. Two, that the changes in the ARAT that we saw correlated with more fine-grained kinematic measures that we also obtained. So I have more confidence that these are true kinematic changes causing a change in the ARAT. But I absolutely agree that going forward, what we need to do is to come up with a kinematicized version of the ARAT that removes the compensatory contamination. I completely agree with you. I do not think that that is the explanation for the reasons I just gave for the dissociation from the Fugl-Meyer. And you know, in the paper, we talk about how you can get a true motor control improvement in the ARAT and not see it in the Fugl-Meyer.
Sorry, can I make a question regarding a very nice point that you were making before regarding the cortical reorganization? Whatever would be the name of that concept, which arguably is very discutable. You've been placing some examples. So for the stroke, I'm an expert, so it makes sense what you're saying. But on the side of other things, as you were mentioning, the amputation or the training of cells of different type to do some tasks, that is not completely true to the best of my knowledge. Because
what isn't true? What isn't true?
First, it's not true if you have an amputation that the things are not plastically changed, because you have both invasion of area. So you have amputated leg and the persons would
actually, we don't have time for that, but that's absolutely not true. That's the perception. Now, I wrote a chapter, which I'm happy to send you, with Tamar Makin, who's at UCL, who's done extraordinary work on amputation, which debunks this idea completely. It's actually very interesting that it's very widespread belief.
Well, how would you explain the fact that, for instance,
I don't want most of the changes in maps that have been described, map changes, and I talk about this a lot in the book and in the chapter in the Gazanaga book, which I'm happy to send, where these are epiphenomenal map changes.
Yes.
Okay, they're epiphenomenal. They're not functionally significant, one. And two, the cause of these map changes is actually, as we argue in the chapter, subcortical. So in other words, it's an involved argument, and I'm happy maybe we can zoom another time, but the basic point is that there are two things that we need to do when we look at all that classic literature. One is, what is the cause of MAP expansions and contractions? Should they be considered reorganization? I answer no. But even if you wanted to call those MAP contractions and expansions reorganization, are they behaviorally causally significant? And the answer to that is also no.
Well, I would argue about the last thing you did. While I agree about the thematics, how do you call it, or wherever it's placed, is irrelevant. I completely do agree about that problem. I would really challenge both you and Tamar, which I know very well her work, about the fact that it is functionally relevant.
Well, absolutely. Well, that's fantastic. I would love.
So we would have a personal chat regarding that. Patients are functionally suffering because of the invasion of the area, so they would refer the pain while going to urinate from the missing leg. So we would
talk about the chat.
Have a nice
you know, this is a fascinating topic. My current interpretation of the literature is in disagreement with that, but we're scientists, and I of course have to be open-minded that there will be counterexamples. But I think that the bias towards thinking that it's relevant and that it's reorganization is enormous, and I'm just trying to counter that bias.
No, I completely agree. That's a nice personal viewpoint, which is not supported by regular literature. So it's nice.
We have another two questions. It's actually super fun from my perspective.
John, actually, I have two questions regarding what you say. But how would you explain that in our animal, which we start training the day after the lesion, there is no recovery whatsoever? They don't go back to.
Well, my equation would say that you've gotten rid of too much residual architecture. You just don't have architecture available.
And then I know I didn't show, and I know we discussed this already, but how, because you say monkey don't develop synergies, right? And what if I would tell you that if the lesion was even bigger than what I showed today, the monkey would have?
Oh, I don't, look, I mean, as I told you, I just got a big grant with Stuart Baker to examine this. And if you go back to the classic studies by Denny Brown, who was the trainer of Twitchell, the irony, right? He wrote a set of lectures in 1948, which I actually tortured myself and read the whole book. And it's not an easy book to read, okay? I can understand why it was left undiscovered. But there are hints in that book that precisely agree with what you're saying, Elvira, that there are ways with cortical lesions to potentially induce them, because the classical models, going back to Kuipers, to Sarah Tower and the others, used pyramidal tract lesions. And as I tell people all the time, the birth of the idea of extrapyramidal came from the puzzle of where did the movement disorder come from, because it wasn't seen with pyramidal tract lesions. So they began to be called extrapyramidal, right? Now, extrapyramidal, well, where, right? And I agree with you completely that it should be possible to try and induce them in a monkey model, which is what we're going to try and do. So don't misunderstand me. It's just to this date, they never get discussed. If you look at Porter and Lemon's classical monograph on voluntary movement of the cortical spinal tract, which is one of my Bibles, right? It's a 400-page book on primate cortical spinal tract and movement. Synergies aren't mentioned at all in a 400-page book on monkeys and the cortical spinal tract. It's the dog that didn't bark.
Nobody had our model for I guess we have time for one last question. Leo, do we have more questions?
Yes, Greta.
Yes, can you hear me?
Yep. Hi.
Hi, thank you, and thank you for the talk. It was amazing. So I don't want to open a huge chapter here, but I also was interested in the concept, of cortical reorganization, and I am aware of all the theory, of course, of also Dr. Makin that goes a little bit against the floor ones talking about the cortical reorganization, but she does also talk about change in the interhemispheric connectivity, and whether, of course, this is also connected to the phantom limb pain. And I'm wondering, well, if she does find this interhemispheric connectivity which is altered, isn't this also per se a cortical reorganization? So I guess my question would be, are you mainly against cortical reorganization, talking about changing of the maps, or also connectivity and all the other phenomena?
You know, I have to believe that somebody set these questions up for me, because I'm so glad you asked that question, right? So we had a paper that we wrote last year where we debunk the interhemispheric competition view for stroke recovery. Another highly attractive notion that I think is completely wrong, right? Now, so in the particular context of stroke, I think it's just gotten us into trouble. On the other hand, if there were changes in physiology between the two hemispheres, it would simply go back to what I said before. The callosum is already there, right? Now, if you're telling me that you believe that you sprout an axon in one hemisphere and it travels across the callosum and synapses somewhere on the ipsilesional side, and that sprouted axon moving across the callosum and making a connection is actually causally relevant to the recovery, then I would admit defeat, okay? But A, I don't think that's ever going to happen in a primate, and two, to the degree that you can detect hemispheric imbalance, that would just be, to me, physiological changes attributable to pre-existing architecture.